Welcome to eHealthTALK, a podcast from Health Informatics New Zealand and hosted by me, news editor at HINZ, Rebecca Macbeth. This podcast provides insight and discussion on key topics of interest from across New Zealand's data and digital health sector. Please be sure to like and subscribe wherever you get your podcasts. Kia ora koutou. Welcome to eHealthTALK NZ. Today I'm joined by Ministry of Health Chief Allied Health Professions Officer Martin Chadwick and Allied Health Clinical Informatics Manager for Te Whatu Ora, covering Waitaha, Canterbury and Te Taipōtini, West Coast, Charlene Tan-Smith. Welcome on the show to both of you. First, for our listeners, can you just briefly describe your roles?
Yeah, thanks, Rebecca. So really simply, as I get to work with my medical colleagues, nursing colleague and maternity colleague, and we within the ministry really have got four key responsibilities. First is that we monitor the health system, that is it doing what is it intended to do. The second is that we're the key advisor to the minister, and if you have to think that the Minister of Health essentially is the overall governor of the health system, so we advise from that perspective. Thirdly, we convene senior leaders in the health system so that we can have a good understanding of what is the opportunities that sit within the health system. And then lastly, we're the kaitiaki, or we are the steward of the health system. And I think that is that last point, which is where we get to contribute a lot, especially within allied health, is that how do we start to identify the opportunities? What are the things that we're not doing that could be doing? And how can we be delivering more effective, efficient and safer care? And all of this, I'll wrap this up in that we try to operate within that transdisciplinary way, that it's how we work across professions, not in a competition way, but how we try to enable each other.
Kia ora, thanks Martin. And Charlene, I should have mentioned in the introduction, you're also, I believe, the chair of NASTAG at the moment. So you can tell our listeners that complicated acronym and what that stands for, I think.
Thanks for having me. Yes, NASTAG is our National Allied Health Scientific and Technical Informatics group. It's quite a mouthful, but you can imagine a whole big group that we are trying to ensure that you have a voice. So in regards to my role, I think of my role as like applied informatics. I get to play at the coalface. I get to work with fellow clinicians to map operational workflows, digital and non-digital, looking for efficiencies. Then I get to design new workflows combining people, process, and technology. So for my doctoral thesis, I was gifted the term heria, meaning an essential weaving together of three parts: people, process, and technology. They are all necessarily together. Then I get to design data structures and data points for what I want to collect, either passively or manually. And with all that is to produce the data dashboards and reports to reveal the story that informs decision operational making, and ultimately benefiting patients by, a result of outcomes of lower admissions, shorter stays in hospital, etc. I like to think of it that I really like doing the landscaping of the gardening, not so much the lawn mowing. So I let the more capable people do that.
Great, thanks, Charlene. And you didn't mention, but you were also the winner of the Clinical Informatics Leadership Award in 2023. And I think you can probably tell from your passionate response to your description of your role why that came about. And of course, we've got the 2024 award coming up this year that's going to be presented at Digital Health Week. So new technologies are always being adopted in health, but how do we ensure digital solutions are designed around clinical workflows and with users in mind?
Yeah, so I think speaking from my perspective is that the opportunity really does sit within Health New Zealand, is that what we have now is a single operator, if you will, within the public health system. So there's that opportunity to start to look at how do we weave some of these things together, to pick on Charlene's analogy there, that there's the opportunity to think that whereas previously we may have done things 20 times over, is that we can really look at how do we do it once and do it well. And I think that is the opportunity to really do that. There are other things that are going on in the background. So if we think about that you've got the Safe Staffing Healthy Workplace unit that is doing a lot of work around trying to collate the data around allied health. And it's those types of things that really weave into that sense of how do we demonstrate the worth of what we do? How do we start to look at what is the right level of allied health input to deliver the better outcomes? And I think for me, that is the key thing that Informatics and the right can really deliver, is that we know at a case level the benefit of allied health, but if we start to lift that up to a systems level, it's building the data, building the information that we can demonstrate that at a system level, that if we get the input correct, if we get the right level of allied health input, that is going to result in a better outcome for our people and those that we've got a responsibility for in the first place. So for me, that is the key driver, having a look at the system. It's about how we now look to do things once, because we can within Health New Zealand. We don't have to do it 20 times over. And also thinking about those that work privately, how we can start to set the tone and start to pull on some of the data processes that they may have in place that similarly are going to support the better outcomes. So whether the payer be Health New Zealand or ACC or other sources, but at the end of the day, it's been able to say it's based on data, it's based on fact, if you will, that this is what we can contribute as far as an outcomes perspective.
Oh, I love it. And it's to add on to what you say, Martin, that's why we all work so well, right? Operational and clinical workflows are the key. Good data design up front is essential. So you start from what you want at the end, and I reverse engineer. So it's just like in Alice in Wonderland, when is a digital solution not a solution? So practicing informatics and clinical at the same time has changed my lens for both. I found the following quote from Lewis Carroll's Alice in Wonderland helpful in explaining it. I find it is an analogy for dealing with a much deeper understanding of metacognition. So, would you tell me, please, which way I ought to go to from here, asked Alice. That depends a good deal on where you want to get to, said the cat. I don't care where, said Alice. Then it doesn't really matter where you go, said the cat. As long as I get somewhere, Alice added as an explanation. Oh, you sure do that, said the cat, if you only walk long enough. So there's nothing wrong with planning. Often I plan the data I want to collect and reverse engineer to the system required to get it. But I think we can understand more from the Wonderland quote. I have become more aware of situations where my metacognition is lacking. When something tugs at you, you realize you don't know what you don't know. This is a good thing, as it creates caution and encourages you to seek. A lack of metacognition is when you don't feel or identify that tug, and you're in danger of not knowing that something you don't know. So not knowing that something you don't know is very dangerous in a clinical setting. I think identifying these situations is a skill that clinicians should develop. Particularly, data gathering should be passive rather than putting further burden on the stretched workforce, as this just leads to non-compliance and junk data. And that's how we work really well, like Martin says, with the CCDM program.
HINS and the National Allied Health Scientific and Technical Informatics Group are running an eAllied Health workshop as part of Digital Health Week on December the 3rd in Hamilton. And one of the themes of the workshop, which I believe you're both going to be participating in, is about turning data, as you mentioned, Martin, into meaningful information. So you touched on it there, but can you talk a little more about that challenge? Why is it so important for allied health?
Oh, okay. So much to go here. I'm going to try to constrain myself. The reality is at the moment that we're working in quite an austere environment as far as funding is concerned. Health is relatively well funded when we start to look at other components of the government system, if you will, but we still need to operate within a budget. And so therefore, how do we demonstrate the ability to provide the best services using the healthcare dollar to best effect? And this is where I feel like I'm kind of standing on the box with my hand raised saying, pick me, pick me, pick me, because there are so many opportunities that sit there that we can be providing services that provide a better outcome for the same or a lesser cost to the health system. And just a really good example of what's happened recently is around how we look at first specialist assessments and some some of the work which has gone on to demonstrate that actually allied health are really well placed to be doing first specialist assessments. So whether it be an optometrist, whether it be an audiologist, whether it be a physiotherapist, there are three professions that the work has been done to start to think about how these professions can be doing that first specialist assessment, because the evidence is there. And I think time and time again, it's starting to really put our foot forward to saying that we know what good looks like, but quite often we may not be doing it in an Aotearoa New Zealand context. So how do we start to build that case? Because there has to be the data, there has to be the informatics that comes up behind us. We're in an environment that you have to be able to prove your case. And there's lots of information internationally, but what does that mean within our context? And so I think that's a lot of what hopefully we can tease into, is that the opportunities that sit before us, because in some ways, ironically, that while it is a little bit more austere currently, it's also a very permissive environment to start to think about how we can do things differently. Because if we keep on doing what we've already done, we will get what we've always got. And it's the opportunity to do it differently, but we must be well prepared for that. So I think that's the opportunity to come and have those conversations, learn from each other, so we can go away and be better prepared to engage in that discussion.
Exactly. I mean, I'm more of a supporting piece, isn't it? So data design is everything. We don't need to collect everything. Junk data is worse than bad data. So it's one part designing your data points correctly, one part revealing the story in the data. Data on its own doesn't tell a story and it doesn't inform, but we're the supporting piece here.
So I guess people out there working in allied health, first, it might be interesting for some listeners, for one of you just to cover, I think there's 50 professions, sort of what we're talking about when we're talking about allied health, scientific and technical. But I would imagine a lot of them think eAllied health, I'm not a data and digital person, like I'm just a clinician doing my job. Do you think, how can we get across that everyone's involved in data and digital these days? And yeah, if you can't tell your story, then of the impact that you're having, then yeah, it's harder to put your hand up and say, I'm worth funding.
Yeah, and maybe I'll add a couple of examples around this. So we've already talked about first specialist assessment, but then if we think about some of the scientific and technical professions that generally can be unseen by the public, but there's a really good example at the moment that if we look at our laboratories, and it's working with entities such as the Institute of Medical Laboratory Scientists and starting to think about what does good look like? You know, can we describe what needs to be in place for a good laboratory for New Zealand and a good laboratory system? But there has to be the data and the information to back that one up. And so that's part of my role, is to really, in some ways, hopefully politely challenge them, but to say, I understand that they're great professions, they do really good work. And alongside of that, we need the data and the information to say that actually this is what we need for New Zealand Inc. This is what we need to have good looking laboratories to deliver the services that we need, because it's a very live issue in the current state. You know, and so that's one instance. You know, I can think of another one. You look at hearing, for example, is that there's really good information that talks about the impact of loss of hearing within New Zealand, but actually, do we have enough within our local context to say, what if we were to address some of the hearing impairments within the population? What would it take to do that? How best do we do that? Where do we need to get the right level of intervention in order to address that? And all of that is reliant on having good information, good data to make those cases. And so it's thinking that we have a lot that occurs within the hospital system that tends to be easy to look at, and hopefully what I'm alluding to here, that there's a whole lot of work that allied health does outside of the hospital system that we need to take into account as well.
Thanks. And what about you, Charlene? As part of your role about getting people, allied health people, enthused about data and digital and what it might be able to deliver for them?
Yeah. How do I make data sexy? I work with a lot of clinicians. I love my job because I literally like being onto the floor right in front of everyone. I often tell everyone that, you know, we have just one big rugby team. And because we know what each other do, we work as a really effective team. However, if you're doing good work and no one gets to know about it and see it, you know, what a waste, right? So, you know, recently I've been nurturing this ACE group, an Advanced Expert Clinical Leads group, and I'm seeing all these wonderful nuggets, and I was going like, why don't we know about your innovation? And that's where, I mean, that's one way of talking about how we can elevate allied health. Another part is also the CCDM piece that I'm working a lot on. We are gathering information of what's happening on the floor, but this is the clinician's data. So getting that data that they give me back to them and going, is this what's happening on the floor? Is this what you're seeing? Oh, no, really? Are you sure? All right, then that's my job to figure out, is it the data points that I got it wrong, or are they just not putting in the data? So they start to learn that data can help to be their voice for them in a collective way so that we can, as a team, achieve all those different milestones that we want to achieve.
Thanks. I love that idea of data being their voice. That's a nice one. So we obviously cannot have a discussion about data and digital without also talking about AI. So what are some of the practical ways you see for getting AI into clinical practice?
Well, the thing is, you see, I'm kind of fighting myself on that. I'm going to be a little controversial. But in my opinion, based on the rate of change over the years, I think 90% of AI implementations we see now will be gone within 5 years and can be completely unrecognizable. But having said that, just in the last few weeks, we've seen a third major AI platform make a pivot towards collaborative workspaces. This is like having a really smart colleague collaborating with you on one workspace as you do your work. This development at the AI engine source has the potential to wipe out a lot of third-party tools currently being touted and sold. The thing is, the advancement is so huge and so amazing and in such a huge spectrum, right? You know, at some point, AI isn't going to be a killer feature anymore because it's going to be standard, but then there is that advanced AI, the kind of stuff that you only see in movies. Just like when I put my VR set on and I can have 5 screens looking at me, you know, and I'm going like, oh my gosh, this is actually quite good. I can be on a spaceport. I can be in a cafe. I can be anywhere, and I actually feel like I've been somewhere. And this is me fighting the VR set with my children, right? You can see virtual reality as well on the education scene, teaching, learning how to do things before you actually do things. There's so many things that we can't even think of that is actually going to happen. I mean, a few things of what I feel that maybe is a bit nearer to us would be, like, for example, Cortex is potential AI exciting stuff that I'm excited about. We're going to be able to take photos. You know, I'm going to send a referral to my podiatrist. And what I'm going to do, I'm going to take a photo of that foot. I don't even need to describe it. She can see that foot. She will know how soon she needs to see that foot. You know, and with that itself, with the data mining of what you can have with it, the potential of the data tracking with that part, you know, blows my mind, make me really excited. I mean, it's obvious that we'll start in health by investigating, you know, letter writing and note-taking and summaries, but the real gains might come from the emerging logic engines rather than the language models. So yes, come to conference, you know, come to workshops. We have so much on AI or the different parts of AI that you can't even imagine yourself. But yeah, sorry, talk too much about this.
We love a little bit of passion and interest, don't worry. How about you, Martin?
Oh, that's why I so wanted to go second, just to let the real expert talk about it before I come in, because I think it's appreciating for me that this is a learning journey that I'm going on, is to really understand, you know, what is the potential that sits within AI. And I think for me, it's about understanding where it is currently, you know, essentially as a large language model. It is a program that will then pull within that and will start to provide those connections. And so within that, you think that the potential, as Charlene was talking about, is absolutely massively huge. And it is an exponential growth curve. The but, however, is, are we there yet? And I think the answer is no. And I think there are 2 key things that I'd kind of put in as I'm beginning to learn and understand more and more, is understanding, you know, truth telling. Is that when you use AI, it can't discern truth from untruth. It will simply look at connections. And so it still requires the expertise of the clinician to be able to do the truth telling. That as you ask the question and you get an answer, can you then test that answer? So I think that's one of the challenges that we have. And then there's a second one, which I know has been actively explored up and down the country, is around data sovereignty. is what happens when we feed data in to some of these AI models. And especially when you think from a totality perspective, when you think about the ownership of the data, how do we manage that? And so here are some of the things that we need to tease through. And so I kind of come back to, are we there yet? The answer is no. Is the potential there? Hell yeah. It is massive what it could be doing. But I think those are the two things that currently I'd put in there, is that we need to maintain that truth telling, that we need to be able to look at what is provided and then be able to provide discernment around that, and just to be very, very conscious around data sovereignty, but huge, huge potential not to take that away.
Speaking of data sovereignty, one of the most widely used AI tools in clinical at the moment is amongst GPs using it for note-taking, and the majority are overseas-based companies providing those. Is your impression that, within allied health, there's obviously a lot of private providers as well. Is your impression that they are also dabbling in this already in terms of the note-taking aspect?
Oh, without a doubt, because I think some of my recent dabblings, you realise what a time saver it can be. So any clinician that is time constrained is going to look to how they can shorten down the necessary parts, but they don't necessarily need their skill set to do. And I think it's about how we try to find that right balance of the potential, the time saving, the good things that happen with that. But, and it is a but, not an and, we do need to hold in that, again, that truth telling and that data sovereignty piece, because if you're feeding patient information into a system, you do need to question who has ownership of that data, because if it's going offshore, there is a query, there is a problem that needs to be teased through with that, because then that sovereignty of that data has potentially been given over to a third party. And is that the right thing to do when fundamentally that data belongs to the patient that you're feeding in about? So just some of those little things that I think we need to be very cautious about.
If we are going to have more adoption of AI, people obviously need to understand the systems that they're going to use. Do you think there needs to be more done around data and digital training for allied health professionals, and is anything happening in that space?
I would say yes. I mean, we're thinking a lot about it, especially as our council. I mean, ultimately, eventually, I feel that I always talk about two curves crossing over, right? So one curve is the existing aging workforce and the challenge of learning to use that digital environment. And then you have the other curve, which is the iPad generation, whose first words are often, is there an app for that? Talking about digital competence is getting more and more out there. I feel in some ways, as much as we need to support the upper curve, to kind of get there, to kind of figure out where they are, I think we need to do some good scoping so we can actually know what is it that they need, what's the gaps, so we can support them as the bottom curve catches up with them, because technology is going to catch up with us quite quick. I think what we need is a good scoping so we can do a good targeted deliberate design on how we can support the workforce.
Yeah, and I think from my perspective, does more need to be done? It's a resounding and a huge yes is the short answer to that. And in some essence, it comes down to how do we define what we do? How do we really build that case? Because if we can't define, we can't count. If you can't count, you can't then demonstrate the correlation and the benefit of any interaction. And, one that I came across just last week was literally, how do we define speech language therapy? Is it SLT? Is it SL-T? Is it SL and T? So it's something so simple, but if we can't get consistent nomenclature that sits around it, it then becomes much more difficult to be able to build that data set, to build that knowledge, to build that understanding, because the benefit of speech language therapy, I could sit here and tell you lots of good things that speech language therapy does, but we need to be able to do that well across the country so we can really start to build that case that actually, if we were to have more intervention of this one workforce, what it would mean from patient outcomes, etc., etc. So there needs to be an awareness, and I think that that's something where allied health can really lift the game, that there's a lot that needs to be done within that. But I think in fairness, it's also very much an emerging area as well. I think a lot of us, myself included, are really grappling, how do we make our play? How do we really understand what are the opportunities that sit within this?
Thanks, Martin. That actually leads us on nicely to the next question, which is, what is the greatest potential or opportunity that you see for data and digital transformation in allied health. And that could be sort of on a small scale, or I guess on a larger, in terms of the impact it might have.
I know I keep saying this, but for informatics, the right data that informs operational decision making. What really improves patient outcomes? What really saves us money? We need to identify and then we scale. On the data front, I'm working on this, but I think that I'm so close. A predictability algorithm for our demand piece in the hospital. And again, you get the right data outcomes. I'll find that algorithm, having a predictability model to kind of see what's coming, that insight would be huge in regards to the operations. That's how we are relevant on the data scale. As far as digital goals, maybe identifying those small, clever tools that remove the day-to-day grind or calculation or free the experienced practitioners up to the work so they can work at top of their scope. And maybe it's those big agile tools that can be molded and formed to fit the clinical practice and improve communication and efficiencies at the allied health coalface.
Yeah, and I think I'll contribute and add into that because I want to answer that in two parts, because I think it's acknowledging that we've got a very large private market for allied health professionals as well. So it's greater than 50% of the workforce is not funded directly through the public health system. So it is that ability to think about having the right information to demonstrate and quantify outcomes. Very simply, why should ACC choose to invest in allied health? And I think that's what informatics can do. It can demonstrate that this is the benefit of investing in these workforces. Within the public system, I think it's the ability to describe the benefit of resourcing. Quite often we know the benefit or the concept of dosage intensity, but do we do it? And if we do it, can we see the outcomes? And so I think there's that ability to really start to grapple with those issues, and especially if you put it into the much broader context, when you look at the need to bring more medical practitioners into our work environment. When you start to increase training, that is a 10 to 15 year journey before you start to reap the benefits of that. And so again, this is me standing on the box, hand up saying, what about us? What about us? There is the opportunity to do something more in the now. And it's a matter of how we really demonstrate that actually we provide solutions in that intermediate to the shorter term, that we can start to look at how we provide services in a different way, how we can provide it close to where people are, how we can actually deliver outcomes that are as good or better than what they are currently. But we need to be able to back it up. We need to have the data, we need to have the information to demonstrate, because there is always competition for the health dollar. There is only so many health dollars, and so we need to be able to engage very objectively in that discussion and say there are always choices. There's always a choice as to how that health dollar is spent. So if it's going to be spent this way or that way, why should it be invested in allied health? And I think that's the type of argument and discussion that I'd love to us get engaged in more and more. Current state this year, it's really been about first specialist assessment. We've really engaged in that discussion. We've been able to demonstrate what we can do, and now we're starting to see that change. And I'd love to see that again and again and again, because that was informed by a whole lot of evidence, a whole lot of data that allowed that shift in that information. And so I think that's the challenge that sits before us.
You're right, allied health professionals are very much embedded in the communities and very close to where the patients are, aren't they? So if you are an allied health professional and you're listening to this, tell us again why they should go along to the workshop on December 3rd and learn more.
Yeah, so I think about, the very limited discussion we've had in this podcast. It's going to be that plus more. There's going to be a huge amount that's going to allow us to explore these topics more. And I think it's about providing that space, if nothing else, that we can actually come together collegially and really seek to learn collectively. And for me, that's my perspective, to be able to share the stage with people such as Charlene and to be really able to dig into that. I know some of the other people that are going to be talking, but we all share a similar vision, which is along how can the benefit of allied health be realised. But there need to be the enablers, there needs to be the support, and then part of that is how we can get people to have that same level of understanding. And so I think that's part of the driver of what we can achieve during our time together, is to get to some of that commonness of understanding. Then we create a shared language, then we can kind of go forth back to the workplaces, and that's what we can continue to build on.
And how about you, Charlene? What are you most looking forward to on the day? I think there's even going to be a panel about using social media, which I thought sounded exciting as well.
Oh my goodness, we got Caitlin Fraser, so she's our vagina physio, Jo Robertson, she's our sex therapist from Married at First Sight, and Polly Newton, who's our speech language therapist that's going to talk, to encourage us in a way on, how can we actually get ourselves out there using social media? How exciting! I mean, among that, we just kind of throw a few things in the mix. We get to hear our leaders talk as well about where to from here for next year. So it's like a one-stop shop place on figuring out where we are in a data and digital world. What else can we do? How can we get ourselves out there and at the same time have a good ekonoki? Did I say it right? I must have said it wrong. But, there's something to be said about face-to-face. There's something to be said about, being able to meet colleagues that we always meet through Zoom or Teams and never get a chance to sit down and have a good cuppa. So yes, come, join the fun. Hence, it's going to be the place to be and the conference for the year.
Thank you very much. So yeah, that's a reminder. It's on December 3rd. If you go to hins.org.nz and click on events, you'll find all of the conference information and the ability to register for the workshop. You also, as part of that, get to attend the plenary session on that evening between 4 and 6, where we've got lots of exciting keynote speakers. We've got the Commissioner of Health New Zealand, Lester Levy, speaking. We have a guest speaker from Dubai, where they're doing lots of exciting things. So it's really the place to be, as you said. Thank you so much for joining me today, Martin and Charlene.
I just want to note that we're recording this on the 14th of October, and the 14th of October is International Allied Health Professions Day, so I would be remiss if I didn't use the opportunity as a shout out to every allied health professional wherever you're working, just to say thank you for your mahi, how much it is appreciated, and just knowing the passion that you bring to your job. So recorded on the 14th, of course, distributed after the fact, but making the most of it.
Absolutely. Wow, that was very good timing on our part, almost like we planned it that way. Thank you for listening. We look forward to seeing you in December. And mā te wā. Thanks for listening to eHealthTALK. Be sure to subscribe and share with your colleagues and friends. eHealthTALK, eHealth News and the eHealth webinar series are supported by Health Informatics New Zealand. See hins.org.nz for more information and become a member starting at just $17 a month. We also have affordable organisational membership options for both our industry partners and healthcare providers.